Mr. Cooper, my name is Dr. Weiss. I've been asked to examine your abdomen today. Is that alright if I carry on, sir?
That's fine.
Lovely. Before I start, have you got any pain in your tummy at all, sir?
No.
Lovely. Can I start with your hands, sir? Just turn that one. That's lovely. Just look up for me. Look up again. Stick it to me. Is that R? Right. I'm just going to lie you flat, sir. Just lean yourself forward, that's lovely. Okay. Bring this back. Just give me a cough. And again. Fine. I'm just going to have a feel of your tummy if that's alright. Take some deep breaths in and out through your mouth for me. Okay. Deep breaths in and out. Just going to press into the small of your back, sir. Just go feel in your groin, sir. Okay. Just give me a cough. On the other side. Give me a cough. Just have a look at the arm. Just let your arm go nice and loose and I'm just going to feel into your arm. That's it. Just let it flop onto mine. That's grand. So now just have a quick look at your legs. That's alright. Is there any tenderness in them?
No.
I'm just going to press. Mr. Cooper, that's very kind of you. Let's sit you up, shall we? That's grand. There you go, sir. Thank you very much. Mr. Cooper presents a classical membership ACES exam patient. He is well and he's an abdominal station patient. When you look at him, he has no evidence of dyspnea, he's not jaundiced or discoloured in any way. When you start at his hands, they're not clubbed, there's no pulmonary erythema, and into his armpits there are no signs of chronic liver failure at all. There are no fistulae. You do note that he has multiple tattoos. He's not cyanosed, he's not jaundiced, important, and he doesn't appear anemic. When you look at his abdomen, on inspection from the end of the bed, there appears to be no flank or abdominal distension anteriorly. Normally flank distensions very often implies renal masses, i.e. polycystic kidneys for example, and girth distension may imply that there is ascites or even a very significant enlarged hepatosplenomegaly. What you do notice, however, he's got multiple abdominal incisions. One which is in the left groin. These are red and therefore not old classically. However, it does imply that it may have steroid therapy, and that's why the lesions are still red and in nature and appear almost like striae. When you examine him, there is no tenderness in the abdomen, there is no gross organomegaly, i.e. there is no liver, spleen or palpable renal masses. If a mass is blottable, then it is retroperitoneal and you think about kidneys. If you're worried whether a spleen is a kidney or a spleen, then think about blotting it. If it's blottable, it's likely to be a kidney. If it's non-blottable and you can't get your fingers above it, it's likely to be a spleen. When you examine the scar in the left groin, which I did right at the start, there is undoubtedly a mass underneath it, which is smooth. Importantly, it's non-tender, and this is a renal transplanted organ. When you auscultate, there is nil to found, there are no bruises in particular, and there are no lymph nodes in the groins or in the axilla. And there is no evidence of fluid overload clinically in this patient. He's not breathless, and there's no ankle edema as well. Mr. Cooper's abdomen has numerous scars. There are scars here in keeping with his previous peritoneal dialysis and where he's had Tenchkov catheters put in. Remember, incision scars may also imply that he's had peritonitis in the past as well. His large scar here in his left groin is where his transplanted kidney is. Now look at the scar, it's nice and red. So it implies that he may be on steroids, and that's why the scar healing hasn't fully occurred. It also may imply that he's had a recent renal transplant as well. Blotting underneath that, you'll find a smooth renal mass. It's important to listen over those to ensure that there's no bruit, and also when you palpate this area to ensure that it's not tender. Mr. Cooper has a left renal transplant and is Cushingoid in appearance. On examination from the end of the bed, he appears Cushingoid. There are multiple tattoos on his body. There is no evidence of pulmonary erythema or clubbing. He's not cyanosed, he's not jaundiced, and he's not anemic. On examination of his abdomen, he's got multiple scars, including scars paramedianly where he's had Tenchkov catheter insertion. He's also got a scar in his left groin, which is still erythematous, implying that he's had a recent renal transplant, or he's on immunosuppression in the form of oral corticosteroids, which has caused poor wound healing. Under the left groin scar is a kidney mass, which is non-tender. There is no other organomegaly in his abdomen, there is no ascites. Therefore, in summary, Mr. Cooper has a left renal transplant with previous evidence of renal replacement in the form of peritoneal dialysis. He's got no other evidence of arteriovenous fistula, past or present. The likely causes in this chap, therefore, include glomerulonephritis, pyelonephritis, diabetes mellitus as the most common causes of his renal failure.